Okay, so I'm Christina. This is Outcomes, and today we're examining a fascinating intersection in healthcare finance, and that's how behavioral health retention strategies create system-wide value. I'm very excited to be joined by Mike Meaney, founder and CEO of One Small Step. Mike and his team have developed an innovative approach to one of healthcare's most challenging issues, and that's keeping patients engaged in substance abuse treatment. Through peer support, they're seeing improvement in clinical outcomes, changing up workflows in healthcare systems, capturing value in the process. What makes this work particularly interesting to me from a financial perspective is how it reveals opportunities that traditional healthcare models often miss. When we talk about patients leaving treatment against medical advice, we often focus on the clinical aspect, but Mike has uncovered how peer support programs create measurable financial returns throughout the entire healthcare system. Mike, welcome to Outcomes. I'd love to start with where you're from and how did you get started in this space?
Yeah, thank you so much, Christina, for having us. And I'm here joined by my co-founder and COO, Zach Glicksman. We are Tucson boys. We're both from Arizona, grew up there, went to high school there. Yeah, I'm now based in the Bay Area in Menlo Park, California, and Zach is still in Tucson.
So welcome, Zach. And can you share how did you get started? You're from Tucson, so you're just down the road from me.
Yeah, definitely. So yeah, I am still in Tucson. I went to the university here, and then eventually got my master's degree in social work. Throughout my career, I started with patient-facing work, doing a lot of work with patients with serious mental illnesses, folks that were on court-ordered treatment, and eventually got into leadership and started working at a psychiatric hospital where I was the director of social work. I had a couple of jobs as a director of operations, and then had an idea, saw some gaps in treatment that some of the places I'd been working at were missing. And at the time was really just an idea. Didn't know if it had legs, wasn't sure if it made sense. And that's when I roped in Mike and our other co-founder, Tyler, who is not with us on this call. And that's where things took off quite a bit. Mike was able to use his background and really look strongly into what the issues are, what the space looks like, and how we could put something together to keep patients in treatment longer, both when they're in residential facilities and also ensuring that when they leave those facilities that they hopefully don't go back through the funnel of high cost care.
Awesome. So when you talk more about the gaps that you noticed.
Yeah, for sure. I can start and then, I'd love to get Mike's take on this too. But a lot of the work that I did was, like I said, with folks that had substance use disorder, folks that had serious mental illnesses, certainly patients that had co-occurring mental health and substance use disorders. Then, of course, that came with some chronic medical conditions as well. What I found was that there's some really phenomenal work that is going on Monday through Friday, 8 to 5. Really good stuff, really great resources. But once it goes after 5 p.m. and on the weekends, a lot of those resources start to dry up. A lot of the staffing starts to get more scarce, and patients are often left with an inability to find people they feel comfortable talking to. And what winds up happening is they're left to their own devices. They don't have somebody who's been there before to talk to them. And a lot of times they'll wind up seeking higher levels of care, engaging with crisis teams, relapsing, going back into hospitals. So the gap that we were trying to fill that I think we're starting to do pretty successfully is identifying that there's a problem after 5 p.m. and on the weekends, and trying to intervene with peer support specialists, folks that have been in their shoes before, and ensure that the patients that need help get it on demand.
So walk me through that. Because I have my own ideas about this and about there is that 24-hour gap, but for listeners that haven't been there, haven't been in that space, or just don't know, what does that look like? So why is it so critical, let's say if like in an ED or, for any of the spaces that you all have your services in. Why is it so critical that it happened then? Like, why not wait out the night and see what happens? Like, where is the sense of urgency? Where does that come from?
Yeah, so I'm happy to share my perspective, then Zach can fill in gaps to my answer. So I'd say there are sort of two different ways to think about it. So the first is like at an in residential treatment program where someone's in like a 30 or 45-day stay at like a rehab. The evening times are when staff are at their lowest. There's often just 1 to 2 behavioral health techs with an administrator on call, often overseeing 30 or 45 patients. These patients are all people in recovery for only a few days, a few weeks at a time, and are still experiencing all of the kind of zoomies that like come with that. You're anxious, you're tired, you're afraid, you're lonely. And at nighttime, that's when a lot of people engage in their active addiction. The nighttime is just kind of a higher, like more frequent source of escalation for a lot of people. And so that's when you start seeing a lot of people think about leaving it against medical advice. It happens at night. And so we seek to provide support for patients who are escalated in the evening times to connect with a peer on our platform and just talk through that escalation with someone. I'm a peer myself, and oftentimes what is happening is someone's escalated, they're facing a problem, they haven't talked with their family, they're anxious about their future, and they just want to leave. And after spending 30 or 45 minutes with someone, understanding what they're experiencing, kind of helping them uh, right size the problem, shrink it down to a set of concrete steps they can take to kind of regain control and de escalate, they'll often decide to wait until the next morning, see how they feel, and oftentimes they stay. So that's the context of like an inpatient residential treatment center. Hospitals in the evening times. So ED admissions in the evening are 2 to 3x more likely to be from substance abuse. So people overdosing, people who are out partying that have an incident as a result of their substance use. And that's when hospitals are stretched the most thin. I think, Christina, from working in an ER in the evening times. And people want to leave treatment. They don't like being in treatment. They sort of come to and are freaked out or scared, and they don't have someone who's been in their shoes. They're talking to a nurse or a doctor who help people with substance abuse, but they might not have that experience themselves. And so that's when certified peer support can help de-escalate a patient, encourage them to stay in treatment and get better to improve their outcomes overall. I guess that was too long of an answer, but Zach, anything that I missed?
I think that was summed up really well. The only thing I might add to that is a lot of the providers that we've worked with and a lot of the providers that we've talked to also indicate that at times there's a feeling of kind of an us versus them in the residential setting. So in the rehabs, the patients are working with the staff, and the staff also have a job of enforcing the rules. And when you're newly sober and trying to work through those feelings, oftentimes those aren't the people that you want to confide in when you're starting to feel anxious or starting to feel like you want to leave. So we believe that by providing this service on demand within seconds, they can connect to a peer who's uniquely qualified to help them goal set and plan, really just to get through that moment into the next day when the staffing is more robust, when they have more programming. So that's just kind of another anecdote that we've heard from quite a few people and from some of the patients in the residential facilities we've talked to.
I want to go back to one of the statistics that you just quoted, Mike. You said that, say that again, about in the ED, patients are 2 to 3 times more likely to be substance abuse related, like that these visits were more likely to be substance.
Yeah, so it was an interesting paper from a few years ago that looked at types of ED admissions at different times of day. And so you've got like the morning, the afternoon, the evening, and at night. And what the paper found was that in the evening and nighttime, ED admits are 2 to 3x more likely to be due to substance abuse. And yeah, I can follow up and send you that paper. I think it was JAMA or the New England Journal of Medicine. It was a highly reputable source. And then speaking with people like yourselves, social workers, other doctors and nurses in our networks, they all say, "Oh yeah, well of course, like it like matches their personal experience that in the evening times ED admits are much more likely to be attributable to substance abuse."
Well, I mean, I work night shifts in the ED, and I can say like anecdotally, yeah, that does seem to check out. But that it's been published, and it's a thing, and people know about this. That's a really insightful. So when you talk, can you talk more about what are some other things going on behind the scenes from the patient perspective that normal, I don't say normal, but like non-specifically focused substance abuse providers might not know about. So like people in the ED, people in these types of settings. Talk more about that.
Yeah. Yeah, so I think it's a great question, and let me also share now. So I myself am 11 years in recovery. I've been clean and sober since March 3rd, 2013.
Congratulations.
Yeah, thank you.
Yeah, coming up to an anniversary there.
Yeah, exactly. Almost 12 years. But like they say in the programs, there's no fronts in sobriety. So I don't know if you can say that on a podcast, but yeah, we'll go with it. Yeah, and then but my work life and my professional training, I'm trained as a research scientist and have worked in product and technology development for the past decade. And so creating this like platform for peer support, certified peer support, is this fusion of these two like really important parts of my life. And I'd say like the key thesis behind it all is that as someone who has struggled with substance abuse, you just think that it is impossible to actually get better. Like you can't actually envision a reality where you're not drinking and using. And for me, I mean, and this is a common story you hear, I was successful in all other aspects of my life. I got good grades. I was a good athlete, had a robust social life. And I didn't drink every day, but the weekends was my like off time. I didn't know how to relax and have a good time without that. And I just didn't think that it was possible. And then it wasn't until I met someone who was really successful in school and life and loved to drink and like party, that was sober. And he was like, yeah, and like I don't drink anymore. And he was like this proof point in front of me, someone that could credibly signal to me that he knew what I was talking about because of how he talked about his drinking. For him to then share that he found a way to live life that didn't include drinking, just like totally gobsmacked me. I had never met someone that could be an actual proof point for me to see. And so I had spoken with doctors and nurses and my parents and my friends, and they're like, you should really get a handle on this. You should stop. You should stop. You should stop. And it's like, yeah, I know. Like, wouldn't that be so nice? Like, I wish I could too. And then to finally meet someone that had been there and stopped, it like finally got my attention. It was like, oh my God, like there is this alternative outcome. I didn't know how he did it. I didn't know what happened. And that started like my long journey of learning. But the key insight is that someone who's struggling needs a proof point of hope, and certified peer support specialists are that proof point that's unique.
I'm just trying to absorb that. When you can't envision a future without using, that's a big statement. That's overwhelming. It sounds overwhelming. What are some other barriers that you can think of? anything else going on that maybe like these traditional models are kind of missing in that picture?
Yeah. So, yeah. And like, I think there's a lot of barriers to accessing successful treatment. And so, like, for example, and just back to like the time of day, right? Everyone gets off work at 5 or 6 p.m. and they go to happy hour and they, like, go out to dinner and people are drinking. And so the evening times are when people are triggered. You have a bad day at work, you pick up your kids from school and they had a bad day. You have a happy hour. There's just all these triggers that are really concentrated in the evening, in the evening time, but that's when most care facilities are closed. And so, like, where do you go in the evening to get support? And traditional 12-step fellowships, which is how I got sober, that I'm very grateful for them, highly effective still after 80 years, is like the gold standard of getting clean. There's a lot of barriers to them, perceived barriers, I should say. Even though they're free and all over the place, people think they're religious or they think they're a cult or they think these things that aren't true, but nonetheless present perceived barriers. And so people don't start and they don't go. And so what we've tried to build is a platform that provides access to that high quality care and a proof point that recovery is possible without those barriers to entry.
Yeah, I think one maybe addition or maybe to underscore Mike's point is I think one of the barriers is just an inadequate real-time resource for people. And yeah, again, kind of to underscore that 8 to 5 window is good, but after that, of course there's options, right? You can call your family, you can try to call a friend, you can try to call, if you're in AA, you can try to call a sponsor. All of those are fine, but when it's 2 a.m. and you want to connect with somebody that you know has been there, you want to do it by text, you want to do it by phone, you want to do it by video, you want to have somebody who wants to be there to help you in that moment. That's sort of where we come in. And we think, again, that we have this kind of unique approach and a unique peer support bench of people that have been exactly where these people are, wanting to reach out to somebody that understands it fully. And when they were doing it, this wasn't available. And maybe it took them multiple rotations to try to find somebody to reach out to, when something like this could have sped up that quite a bit. So I think that's just maybe another little barrier.
Yeah. And if I can just add one more thing, Christina, and then you, of course, can edit out all of the extraneous content that we've shared. But my last point will be,
It's good. It's good. It's all good.
as a certified peer. So what's so cool about the peer certification programs is that they really take an approach of, there are many paths to recovery and there are many paths to harm reduction. And so the traditional medical world, unfortunately, is often focused on treating symptoms, of kind of stopping the bleeding, right? And doctors and nurses and a lot of other professionals are trained to help deal with the immediate sort of crisis in front of them, but that doesn't always treat the underlying causes. And what peer support does, as a certified peer support specialist, you are trained in all of the modalities of long-term care. You might help someone find an AA meeting. You might help someone find Celebrate recovery meeting. You might help someone find a SMART recovery meeting, which is like a rationalist approach. Someone might not be ready for that. So you just might talk to them for a half an hour or 45 minutes or 60 minutes as they think out loud about their own barriers and challenges. There are multiple successful paths to recovery. Speaking with a certified peer is kind of the earliest entry point to that. And we've just tried to radically improve accessibility to that entry.
I think this is a good time as any to talk, to segue a little bit and then talk about when you have patients in a in a system that's it's got like a million, seeing millions of patients, seeing or thousands of patients, just depending on where you are. Talk about the impact of these AMA discharges or these these patients that don't have that, appropriate amount of support in these settings. So tell me about that.
Yeah. So Zach, you want to start on that one?
I mean, I can tell you about what that looks like, and then I'm sure Mike can pepper us with some good stats from some other papers perhaps. But yeah, when these patients don't have the support they need in real time, I think inevitably what happens is they start to spin out a little bit, they start to leave, and then the real issue happens once they do leave. They're usually not leaving to go to an AA meeting, right? They're not leaving to go to their friend's graduation. They're typically leaving substance use residentials because they feel better and maybe they want to use, or maybe they just don't want to feel the feelings that they're now all of a sudden feeling. So when they leave, that's sort of where those downstream effects start to happen. Those patients maybe start using again. Those patients wind up maybe back in an emergency room, have to go back through that funnel of high cost services. And it takes that many more times to try to help those patients graduate those programs, move to lower levels of care, graduate those programs, and then be able to start moving through the outpatient world sober and attending appointments. So that's at least one piece. And then just generally also from my own experience, and then I'll let Mike talk more about some of that. But working in a facility where patients are leaving at a pretty shocking rate, as a staff member and as a leadership person, you start to think, are we not doing right by the patients? Are we not having the programming that we need for the patients? And I can certainly tell you that it is incredibly more rewarding when patients graduate treatment and they successfully go through the process and you do feel like you're helping. That's why we get into the field to begin with. And when you start to see patients leaving against medical advice over and over again, and you don't feel like you have the tools or the resources to be able to help them in real time, you start to look at other places to go. This is not working for me. And when you start to lose staff or you start to have staff that have job satisfaction issues, that then becomes the culture. And it takes a long time to try to figure that out. And so, what we're trying to do at the lowest level is, at an absolute minimum, helping the staff that are there. Oftentimes, they're kind of outmanned. It's like a 1 to 20, 30 ratio after hours. We want to support. They're one person, they can do a lot, they care, they want to be there for the patient, but there's only one of them. They can't multiply yet. So we want to be able to help when patients need help, to be able to increase certainly patients completing treatment, but also be able to help the job satisfaction of the folks that are working in those facilities too.
Yeah. So I think so much to unpack here, Christina. So let us know where we should expound. But basically, if you look at the highest levels of care, so in an ED or ER, in a detox hospital, or in an inpatient residential treatment program, the rates of patients leaving against medical advice range between 20 to 50% of patients. So,
Wow.
I mean, that's pretty astonishing. And obviously, high variance. There are certain facilities that do a remarkable job and have very few AMAs. There are some that regularly have AMAs over 50% of their population every year. If you leave against medical advice, you are basically guaranteed to relapse. And just some of the stats that indicate this, I mean, there's so many papers on this, but one paper found that 54% of patients that leave against medical advice were hospitalized within the next year. Another recent paper, I think from 2023, found that patients who leave AMA are 12 times more likely to be readmitted in the next 14 days. So if you shrink down that interval of time, when they are readmitted to 14 days, they're 12 times more likely in the next 14 days. They're 3 times more likely to end up homeless. There's just so many outcomes that are associated with people leaving AMA. And it makes sense, right? Because if you leave against medical advice, you're not completing your treatment program, you are less likely to get better. And I think like the hidden cost of this is, instead of being in an IOP program or therapy or a free program like AA, if you leave against medical advice and are not put on a successful treatment program, you end up back in those higher levels of care, which are thousands of dollars um, per visit. And so is kind of the key variable that we help providers focus on. And certified peer support is shown to reduce AMAs by between 10 and 30%. There's a lot of work here looking at certain statistical modelings that are quasi experimental. There's also like randomized control trials that show that impact is real. And AMAs can be reduced by about 10 to 30% when peer support is implemented effectively.
Wow.
Yeah, and so that's really the predicate of our model.
When you we'll talk about the other factors too, because you said that I mean, if you happen to know, sorry, I'm not trying to like quiz you on some of the research here, but I mean, when you talk about how some facilities do better than others when it comes to their AMA stats, what are some factors that can kind of make that difference?
Yeah, so that's a great question, and Zach's probably more equipped to answer it than me. But just some of the high level things are, it's really like resources, just like resources for care. So a lot of higher end out of pocket facilities that take commercial insurance and just have much more robust budgets, have more staff, more treatment modalities, like more coverage, lower patient to staff ratios. All of that contributes to the quality of care and actually crisis mitigation. Um, because like the staff ratios don't matter all the time, but then in crisis moments when things are escalated, that's when staff ratios really matter. And so I would say that it's really just resources. And as you might imagine, CUD patients are, I think, 3 to 4 times more likely to be on Medicaid than a non-SUD patient. And so a lot of these individuals are from lower income backgrounds and depend on Medicaid. A lot of the treatment centers are lower resourced, understaffed, have huge like waiting lists, and just can't provide the care. And so that's where a lot of these factors concentrate and like yield some of these more challenging outcomes. And so, as is so unfortunately common in our society, the places that need the most help and are most adversely impacted from a lack of resources have the fewest amount of resources. And then the bad outcomes are concentrated among those who can least afford them. And so that's kind of how I would think about it. Zach, I don't know if you'd add anything.
Not much. I mean, just maybe more anecdotally, just from provider engagements that we've had and calls, we're finding that these kind of more boutique 10-bed places maybe don't have as big of an issue with patients leaving against medical advice. When you start to expand that, that's where we're starting to see those numbers creep up into the 20%, 30%, 40%. I mean, we've heard from somebody directly in a residential that has a 70-bed substance use residential that is predominantly Medicaid, that their AMA rate was 50%. Now, again, what's the cause of that? Mike laid out a few. I think resources is huge. Staff training obviously is huge. We don't profess to cure anybody. We don't profess to get their AMA rate down to zero. But what we do profess to do is to be able to provide that immediate solution for patients and ideally catch them before they've escalated all the way to the top of that cycle and intervene down when things start to feel like maybe they're getting out of hand. Once they get to a point where they're at the highest point of that escalation cycle, bringing them back down is more challenging. It's not impossible. But if we can intervene and build that rapport early on, as a trusted, unbiased third party peer who's been there, that's where we've found that we have the best results in curbing some of that AMA. And then just kind of more like on the mental health side, because there is mental health residentials as well. Their AMA rates are a little bit different and slightly harder to kind of track, only because they have a lot more ability to intervene with the patients from like a court order type of place. If the patient is leaving and they're not safe and they're a danger, they have things at their disposal to be able to keep those patients in the residential or have them go to a higher level of care. So that's a little bit different on that side.
So I'm clocking in to a long weekend tomorrow night. So again, I work at a large safety net system, and we have a lot of patients that come in for substance abuse related crises. So we don't have one small step in place. We don't have a third party in place, as well as a lot of like these rural hospitals, or just how can I, as just an individual, a regular frontline staff member, better support these patients while they're going through this, while they're making this change for themselves, or trying to, so that way I can kind of mitigate the risk of an AMA.
Yeah, so it's a great question, and I definitely think something that we're trying to help do is just like grow access and like expand the reach of what we are doing, and kind of augmenting the incredible work that you and your colleagues are already doing. I think that the key insight, I mean, and as a social worker, you both know this, but a lot of times I think what we find is cycles of escalation tend to become most acute when people are feeling overwhelmed, and like they feel like they can't get out of some cycle of negative thinking escalation, oftentimes where like you're just kind of in this swirl of pessimism, and the future just feels bleak, and you want to just get out of how you're feeling. And so what I do is I always try to start with the patient talking through the source or impetus of that feeling of escalation. What happened? What caused to start the cycle? And validate that that's a real legitimate cause. And if you got fired, or if someone close to you passed away, or if you went through a bad breakup, or whatever happened, that's a shitty thing to experience in life, and totally valid that you're having this like reaction. And so validate what they're experiencing and talk through your own experiences dealing with that, so that they don't feel alone. And then after that, I try to just break it down to a really small problem. So stepping back and not thinking about never seeing someone again, or being alone for the rest of your life, or like not ever finding a job. It's like, what's one small step? What's one concrete thing that you can do to just make a little bit of progress? Is it, it's, and immediately I can say, you're already doing a great job because you're talking to someone about it. And so just start them in that positive validation cycle immediately. Look at how great you're already doing sharing with someone. You're doing a great job communicating your feelings and expressing what you need. And start to just take that negative moment, and just like through a very small, tangible thing, start a positive cycle of like validation. And oftentimes people will calm down and see a bit more clearly, and not feel as overwhelmed. That's how I think about it. I don't know, Zach and Christina, I'd be curious if that resonates, but that's how I think about it as a peer.
Ironically, Mike came from like a very clinical approach, which is like amazing, and I will go to a very non-clinical approach, which is kind of at times what I do. But I can tell you, Christina, to maybe answer your question, right? You work in a very like high acuity place. You're in an emergency room, and when I was at a hospital where I was the director of social work, a lot of times it was my responsibility to go to the patient, de-escalate the patient, try to convince them to stay with mixed results. But one thing that I found really effective is these patients have likely gone through a number of different people to get to you. They've probably talked to an intake clinician. They've probably talked to a nurse. They've probably talked to a doctor. They've talked to whoever, the ambulance driver when they were there. And they each pass, they've been asked, are you going to hurt yourself? Tell me about how that feels. What substances are you using? Does it, whatever. At some point, these people are humans and they probably get sick of talking about that a lot. You have to do what you have to do. You have to assess the patient. You have to screen the patient. You have to make sure they're safe. But what I found really rewarding and what I found to be somewhat effective at times was just to go into the patient's room and talk to them about the shirt they were wearing. They're wearing an Eagles shirt. Christina mentioned she's an Eagles fan and she had a good weekend. So, if she's wearing an Eagles shirt, I'm going to go in there and say, hey, like, how are the Eagles doing? Like, I'm a big Packers fan. Let's talk about that. And I think people find that refreshing to not have to consistently over and over again tell the same story. That's the not clinical side for sure. But on the clinical side, kind of definitely doing a lot of what Mike does, trying to assess like where they're at. Are they in pre-contemplative? Are they contemplative? Are they now at a point where they're starting to hopefully take action and are receptive to resources? And so trying to tailor what you are doing and what you're offering the patient to what stage of change maybe they're at that hospitalization.
Well, this has been so enlightening and very educational. And I want to thank you both for coming on the show and sharing all of this with us. How was it? How do you feel?
Yeah, it was amazing. You're phenomenal.
Yeah.
This felt great. Yeah, this was very this was great. You made it very comfortable for us. Thank you.
Great. Yeah, I'm glad I could be your peer support through this.
Yeah.
So, yeah, go ahead.
I was going to say, I don't know if I like how quantitative and numeric you are, Christina. So I obviously came to play with a lot of my research. And I'm just wondering, like, if you think,
I love it. That was awesome.
And I think like one thing that we didn't get to share about the impact, like the outcome of peer support, is that when people, so like we talked about people leaving AMA, but the other thing that the research literature shows is that when you work with a peer in treatment, future hospitalizations go down. So there's a 2021 paper that found being in SUD treatment and working and having that augmented with peer support leads to a 44% reduction in hospitalization and a 9% decrease in ED visits within 6 months post working with a peer. And then importantly too, a 66% increase in outpatient care visits. And so, like, one of the interesting things is that the summation of all of these findings is that the HEDIS measures recently were updated to include peer support for post-acute follow-up care. And so that used to be only a psychiatrist or a nurse practitioner or a licensed counselor. You can now visit a peer in that 7 to 30-day window after an acute mental health episode. And that will improve the HEDIS quality measures of those health plans. And so, sorry, you didn't ask this question, but I know you like all of the data and the saving money and like health plans and HEDIS and all these other parts of the system are starting to see that the reduction in crisis care as a result of working with peers is real, such that they're now included in these key quality metrics.
That is so great to know. I wish we had more time to dive into that. But Mike, why don't you tell us where we can find more information and where we can reach you and all that kind of stuff?
Yeah. Thank you so much. So we're just at onesmallstep.io, onesmallstep.io. You can email me at mike@onesmallstep.io or Zach, ZACH at onesmallstep.io. And we'd love to partner with you and figure out how we can support your organization.
Okay. All right. Well, thanks so much again and have a lovely day. Goodbye.
Yeah. Thank you so much, Christina.